We should get started. Um, all right. So, my name is Ilan Dinstein. I was in Idan's shoes until a year ago. Now I'm on sabbatical in the U.S., which is a lot of fun. Can you, Michal, Ilan, Yair Tzedaka, Chevre, let's close the door and yeah, thanks. So it's great to be here, and it's a huge privilege to introduce our second keynote speaker, Lonnie Zwaigenbaum, who is here from, we managed to bring him all the way from Canada. Thank you, Lonnie, for coming. Lonnie is a professor of pediatrics at University of Alberta. He did his training at Queen's University and Hospital for Sick Kids in Toronto, and I really think of him, I've been following his work for years. He's really a forefather of autism research in Canada. And the other amazing thing about him is how humble he is. And at some point, someone told me that they did this analysis of, you know what graph theories are when you look for connections between things, that they did a graph theory about autism researchers. And they found that Lonnie is the biggest hub, which is a hub means that you collaborate with the largest number of others, and since he's such a nice person, I assume that's why that's the case. So Lonnie, please come up and tell us about earlier intervention, earlier diagnosis.
That was so nice. Thank you. So thanks, Ilan. Thank you to Don and the whole leadership team at the Azrieli Center. This has been such a fabulous conference, and I'm so impressed that all of you here are at 5 p.m. on such a long day. I hope that this presentation is worth keeping you here until the evening. I'm really excited to present. I feel like I'm among friends and family here. It makes it so much easier to present. My social anxiety gets the worst of me, but here we go. And I get to talk about something that's actually really important to me. I think my own trajectory in autism research, I actually started doing a fellowship in autism genetics, and then had the great fortune of working with some colleagues on one of the first early detection studies focused on infant siblings. I'm also a developmental pediatrician, and I have a number of clinical colleagues, and I really feel like we've needed to shift the way we think about diagnosis, not just about early detection and diagnosis, but rather timely diagnosis and thinking about how that applies across the lifespan, and just our collective responsibility to make sure that individuals on the spectrum have an opportunity to have that self-understanding and the benefits that accompany a diagnosis. And at the same time, to sort of think about sort of how categorical diagnosis integrates with sort of along the broader continuum of human diversity, including children and adults who are in need of supports and services across the lifespan. I will start briefly with disclosures. Our group has been fortunate to receive funding from a number of sources. I do not currently have industry funding or particular sponsorship for this work. Just very fortunate to have support to have a chance to participate in this conference. So even though it's about timely diagnosis, I will talk a little bit about sort of where we're at in terms of recognizing the early features of autism. This has been actually a really exciting conference to hear about progress both on the behavioral side as well as the biomarker side. Stefan really set the tone for the day with a kind of a beautifully elegant presentation, sort of understanding concepts in genetics and how it may ultimately inform both diagnosis and also treatment by sort of understanding the overall neurobiology. It's always kind of 2 steps forward, 1 step back, and I'll really emphasize not only the progress, but also the challenge of diversity and heterogeneity, not only across the spectrum, but including early in life, and sort of the risks of thinking about autism as a single group and making sure that we're parsing out some of that heterogeneity, which is clearly relevant for the practical goal of detection and diagnosis, which, whenever we have a tool, we actually apply it at an individual level rather than a group level. So it is important to acknowledge sort of where we're at in terms of measurement. I'll also kind of talk about the interface between early detection and the reality of age of diagnosis, and sort of make the case that there's a bit of a disconnection right now. Sort of the more and more we push the envelope, we have the ability to identify early features, and I think clinically we recognize that more children are coming to attention at an early age. But of course, our view of that is sort of limited to the children that are making their way to us. And when we look at a population level, the age of diagnosis hasn't really changed all that much sort of over the 10 to 20 years that we've been making progress through prospective studies of infants at higher likelihood. So I'll talk a little bit about sort of, kind of where we're at in terms of strategies to actually get some traction in improving the age of diagnosis and how they might apply across the age continuum, and sort of, some specific thoughts on continuing to move the field forward. I do want to acknowledge that until fairly recently, most of what we knew about early development in autism came from the stories of families at the time that they came to clinical attention and were referred in for assessments. So, those rich recollections, I think, have informed most of our early detection toolbox in terms of early screening tools and sort of our surveillance approaches. But for the most part, children weren't really coming into us until 3 or 4 years old. So that earlier period of time, we're having to kind of reconstruct through the retrospective lens. Now, in particular, through the last 15 to 20 years of prospective research in various groups of infants at higher likelihood of autism, we are having more of an opportunity to directly assess the precursors of autism, both in terms of early behavioral features and increasingly neurobiology and other ways of looking at sort of specific quantifiable markers. I think that actually opens up new frontiers in terms of how we can support these children and families at an earlier stage, particularly during this kind of period of time where the features haven't fully consolidated into a diagnosis, at least that is within our kind of clinical experience and sort of clinical judgment. It sort of puts us kind of where families have been for many years, sort of recognizing differences, identifying sort of areas of function that children could benefit from. It does also take us into this sort of brand new world. Let's see if I can figure this out. Is that? Maybe not. I failed the first test, okay. In terms of this notion of pre-symptomatic diagnosis, and that is sort of a real notion now in terms of thinking about statistical likelihood of autism based on measures, including biomarker measures that aren't directly tied necessarily to clinical features. And I think that we do have to kind of grapple with the potential benefits, but also the downsides in it, and really how little we know about how to sort of modify likelihood of autism or the expression of autism by kind of starting our approaches even prior to the onset of behavioral features. And I'll talk a little bit more about that. A lot of the work that's taken place around infants at increased likelihood of autism has really been from families where there's a child with autism and then a younger sibling. I don't think there's any one group that's going to be fully representative of all individuals with autism. And I want to acknowledge that there's been other strategies, like starting with biologically defined subgroups, children with particular prenatal exposures, as Stefan alluded to, children with known genetic conditions that can be diagnosed, kind of shortly after birth. There's also important work looking at infants born prematurely and also children identified through population screening. And they all have their potential contributions and limitations in terms of the lens. I do think that infant siblings have been especially informative because it allows for sort of broad diversity because you're not selecting on the basis of a particular subtype. In terms of mechanism, that heterogeneity can be a challenge, but in terms of mapping the range of early presentation, I think it has some advantages. It is also distinct from sort of studying autism simply on the basis of clinical referral because we have the opportunity to see these infants and toddlers before they would necessarily come to clinical attention. So our infant sibling study has been amazingly going on for about 20 years now. We actually completed the follow-up, at least for now, of the original cohort who are obviously well into their teens or close to 20 now. And we're actually just starting to bring them back to ask them, what should we be asking you now? And it may be sort of a very different set of features. Of course, it's interesting to know sort of what some of the early features might be that would help predict the later clinical profiles, but there may be other things that these adolescents and young adults want us to learn about. What I'll focus on today is really the early years, so like the first 5 to 8 years, and what we've learned working with these families. So again, these are families who had a child with autism and a younger sibling. I'll be using kind of increased likelihood as opposed to high risk, sort of for reasons that I'll explain in a moment. Our original study had a number of measures. The ones I'll be focusing on particular today are an interactive measure of early features, kind of a broad range of developmental measures, early emotional reactivity, including measures of temperament, and then just to know that this is a group of infants that we brought in starting at 6 months of age, and then they had independent diagnostic assessment at multiple time points, including age 2 and 3. If they met criteria for diagnosis earlier, we assessed, we provided that diagnosis clinically, and then we did continue to follow them at regular intervals afterwards. This kind of decision about language, I just want to acknowledge that, that at least our group has shifted to using the term likelihood rather than risk. And as many of you recognize, this is part of a broader discourse within our field now about the language of autism. And I think this is a bigger topic than I can kind of give proper attention to in a moment. But I do think that there's a shift in terms of thinking about finding the balance between achieving precision in our scientific language and sort of thinking about the message that we're conveying in the words that we use. And I do feel that we can convey a lot of our scientific concepts by using neutral descriptive language. I mean, just as an aside, for the last couple years, I've had the experience of lecturing to undergraduates, kind of giving them the overview of autism, like medical students and also pediatric residents. And for the first time in the last couple years, I've actually co-presented with an autistic colleague, sort of whether someone who does research, and more recently, I have a master's student who's diagnosed with autism. And I really feel personally that what, the language that we use sort of in a scientific setting or with a group of colleagues, we need to be able to feel comfortable that the vocabulary we're using would be comfortable for an autistic colleague. And that has, I have to say, I went back to my slides and had to make a number of changes because our clinical training, including the DSM framework, is very deficit-based. There's no question about that. It takes a while to get our heads around it, but I feel like we can convey the concepts in a more neutral and descriptive way. And I have to say that that's had quite a profound effect on me in terms of when I talk to families about a new diagnosis. And even just the words that we use and the ability to convey hope and sort of really emphasize sort of the promise and potential of their children, I think really makes it a very different experience. So I alluded to this interactive scale for infants. It covers a range of features. I'm delighted to have had a chance to work with a number of you in this room in terms of incorporating this measure into your projects. And it is an assessment tool that's been used in a number of international studies. It's been around long enough that we've been able to evaluate it. It does have good reliability. With colleagues in Seattle, we were able to look at sort of the live rating versus kind of blind rating from video, because we always worry a little bit that maybe we're a bit biased and sort of anticipating more features because we know who are younger siblings and who are not, but the agreement between blind ratings and live coding is actually quite good. And I'll present data just demonstrating that there's been independent validation of its predictive properties as well. So this is kind of the broad view that presents a somewhat optimistic a picture of how we might be able to predict autism sort of on the basis of this brief interactive tool. And these are the total scores on this measure, and separating out the infants at increased likelihood, so the younger siblings who go on to a diagnosis of autism versus those who do not receive a diagnosis of autism versus those at low likelihood, so who don't have a family history of autism. So if you just look at that high group level, there's really quite clear separation by 1 year of age. And interestingly, at 6 months, certainly the two sibling groups, the ones who go on to develop autism and the ones who are not diagnosed by the age of 3, are very, very similar. And again, this has been independently replicated by a number of groups. I mean, there is a hint of a difference at 6 months, which I'll comment further on, but very small effect sizes. In contrast to by a year, really quite a robust difference on a group basis. In terms of sort of what those features are by a year, it's largely a translation down to from what you see in preschoolers diagnosed with autism. So a range of social communication features and sort of some early correlates of repetitive interests and play patterns. So not surprisingly, these are infants who don't respond consistently when their name is called. You're not getting back and forth babbling, and largely these infants are just a bit quiet and don't necessarily initiate a lot of vocalization. We do see reduced eye contact, less sharing of joyful expression, and then again, some of the sort of more second category of features, like difficulty transitioning between activities, getting a bit stuck on a particular toy or activity, and even by a year, seeing some unusual sort of visual exploration and tactile interests. And there are a small number of children who just don't engage, not just socially, but don't really engage with the physical environment. And not surprisingly, those are infants at particularly high likelihood. A little bit different at 6 months. It's been so interesting to see the number of presentations at this meeting that are focused on motor development, both early in life and post-diagnosis. And interestingly, the only item on this measure that distinguishes between siblings who go on to develop a diagnosis of autism and siblings who don't is actually motor control. So, sort of truncal stability, quality of reaching behavior is quite consistent with other infant sibling research that have looked at early motor development in other ways. Intriguingly, we also see a few items that are different between the infants who develop autism and the infants who don't have a family history, but actually relatively similar to the other infant siblings. So as a group, the siblings don't show as much anticipatory social response when they're playing a game of peekaboo, subtle reductions in eye contact, and both underreactive and overreactive. But again, that doesn't predict autism within the sibling group. This meeting has been incredibly rich with discussion of broad biomarkers in the first year of life. And I think there's actually been very exciting progress in terms of sort of mapping both the neurobiology. Broadly, there are these other categories. I know that Ami Klin presented at this conference a few years ago. This is like his earlier work. Ami Klin and Warren Jones have this exquisite data that they haven't quite published yet, possibly because of the commercialization activity, but really looking at sort of the dynamic gaze patterns sort of in response to a kind of a video of social scenes and sort of looking in real time at how gaze patterns can distinguish infants at much higher likelihood of developing autism versus those that don't, and whether that kind of quantification of social communicative behavior might identify autism at an earlier stage and be applicable in a clinical setting to, say, support a community physician and in sort of knowing who to focus on. EEG, ERP findings, sort of both resting EEG and sort of more response paradigms have also been very informative. The details are reviewed really nicely in a recent review that's just published online by Jerry Dawson, Mark Johnson and a colleague in Lancet Neurology, really going through in detail sort of on the state of the science in infant SIB research. I think the EEG literature is more focused on comparing infants who develop autism or are diagnosed later at a group level versus those who don't. So for diagnostic purposes, I think we're still learning about the potential. And then neuroimaging, a lot of that work has been done by a group in the US led by Joe Piven, the infant imaging study that I've had the pleasure of being part of. And it's quite remarkable. And it really shows the power of both looking at early brain development and also the power of machine learning in sort of identifying sort of particular biological signatures that may be predictive of autism. So it's interesting. We heard about head circumference and brain volume today. On longitudinal MRI, the earliest predictor was actually sort of increase in cortical surface area, which is really interesting and kind of preceded increases in brain volume. And using machine learning, and again, this is an important caveat, sort of calibrated to a 2-year diagnosis. The accuracy is like remarkable, and these are not necessarily children who have overt symptoms at that stage. Work also coming from that group looking at kind of both functional and structural connectivity also has sort of very high predictive accuracy. But again, this is sort of based on 6 and 12-month data where the features may not yet be present. Rebecca Grodzinski from that group published kind of a thought paper on pre-symptomatic intervention kind of about a year ago that we were actually just at the Baby SIBS research meeting, and it had a somewhat mixed reception. And I think that we genuinely are grappling with both kind of what the starting point might be in terms of working with a group of infants at higher statistical likelihood of autism, but who don't necessarily have any particular treatment targets. And sort of can we extrapolate from what we know about some of early features and mechanisms? I think we're on much more solid ground in terms of symptomatic intervention. Again, this is a pretty conventional approach in the infant and toddler world in terms of identifying concerns on a less categorical way and really sort of kind of tailoring intervention to sort of what the functional skill needs are. A nice example of that, and of course I'm very biased because these are colleagues of mine, is the social ABCs. Big shout out to Judah Collar and his group at Hebrew University, who are one of the collaborating sites with Jessica Bryan and Susan Bryson and the group who developed this intervention. I think it is a nice illustration of the approach because it doesn't wait for a diagnosis of autism. It is very much targeted to children who have early features. So for instance, what might be identified through our interactive measure or what simply might be identified in the community, people sort of recognizing early features. It is one of the naturalistic developmental behavioral interventions. The behavioral aspect comes from pivotal response training, but it is more focused on specific developmental skills, specifically shared positive affect and directed vocalizations. And it's somewhat unique in that there's no modeling involved by the therapist. The therapist or coach, their role is entirely to work with the parent to kind of encourage them and coach them through their skill development and allow them to develop their own style, but in a manualized program. So there's a level of fidelity that they're trying to achieve. But it's much more about rather than rigidly following a sequence of skill delivery, it's much more about the parent responding to the child's communicative bids in the moment and sort of structuring situations to really encourage that shared affect and directed vocalization. Okay. Oops. Why is that not advancing now? Okay. There we go. So there have been a number of trials. This is the original trial, kind of in a controlled setting on in person and individually. Parents who complete kind of relatively brief training do achieve fidelity in the skills, and the children do show improvements both in directed vocalization and shared positive affect. And it's impressive that those outcomes are correlated with the degree of fidelity that the families achieve. And that subsequent work with the social ABCs, it does not want to advance now. Here we go. Okay, great. Has kind of been in a variety of contexts. So taking it from the lab into the community, working with a broader range of service providers, during the pandemic, administering it both online and in a group setting, and it seems to be relatively robust to those various conditions. So Jess's work is now focusing on international collaboration as well as kind of scaling this intervention, which has actually become the primary intervention in one of our smaller Canadian provinces and also kind of one of a menu of interventions in a couple other provinces. I have to say, sort of kind of collaborating locally with folks that are doing this, it's still a relatively intensive training process. And I think we still have some work to do in terms of kind of supporting colleagues in the early intervention system with an intervention that does require sort of like more intensive training, sort of perhaps different benchmarks in terms of fidelity, in terms of the specifics of coaching than might be sort of in a conventional early intervention program, but which kind of across a variety of families, infant, sibling or not, it does seem to have these benefits for these infants. All right, so that's those are most of the kind of the rosy findings that I'll present today. I want to shift gears and talk a little bit about, if we start to unpack that group that show that separation between 6 and 12 months, and just acknowledge the messiness of the business that every clinician in this room and probably most researchers are aware of, that there's incredible diversity among our autistic clients, whether they're children or adults, and that diversity translates to the first 3 years of life. So how about if I map those AOC scores, and rather than using the outcome as the classification, simply looking at the variation among the group when you throw in both the younger siblings as well as the infants that don't have increased likelihood because they don't have a family history. So based on statistical methods, group-based non-parametric modeling, you do see 3 trajectory patterns, sort of what happens with the scores between 6 and 18 months. And there is a group that show high scores and increasing scores, and then 2 other groups that show more stable scores, one that's more moderate, and one that's kind of somewhat lower. And that inclining group is really the smallest of the 3 groups. Now, it won't surprise you that there's really quite a high rate of autism among those infants who have sort of that high and inclining scores on this measure. But that 39, 54, and 44 are all the children with autism diagnosed at 3. So you can see that they're actually relatively evenly distributed across those 3 trajectory patterns. So, I have a good colleague that asked me, well, should we be screening or assessing for autism at one point in time? Or based on it being a developmental condition, shouldn't we really be looking at the trajectory? So this was kind of our attempt, but it was a bit disappointing, to be honest, because although the specificity of the inclining trajectory is quite high, there's really only 29% of the total autism sample at age 3 that falls in that category. And then even if we try to extend sort of our surveillance benchmark to include the moderate group, I mean, that increases the sensitivity but drops the specificity quite considerably. Now, I will say that we've put ourselves at a bit of a disadvantage because we're doing this initial assessment from 6 to 18 months and then asking the question of what the children are like at 3. If we ask the question of what the children are like at 2, which in some respects is a more logical thing to do if we're trying to link early detection to diagnosis, the sensitivity and specificity values are better. But that does raise some really important questions about what's different about being diagnosed at age 2 versus age 3. So we've looked at this, as has kind of the broader Baby SIBS Research Consortium, which includes quite a number of sites in the U.S. So in our sample, we had sort of just under 400 children who were followed to age 3. Not surprisingly, sort of based on the existing clinical literature, when autism was diagnosed at age 2, almost all of the children ended up having that diagnosis confirmed at age 3. Historically in the literature, we've referred to that as diagnostic stability. I think for the epidemiologists in the group, it's actually positive predictive value. And, in the clinical world, we rarely have the opportunity to follow children not diagnosed with autism, largely because they don't tend to be referred to us. But in our cohort, in fact, 47 of the 103 diagnosed at age 3, were not actually picked up at age 2. So we were curious what those children looked like, both kind of at age 2. And when we divided the children with autism based on when we actually made a clinical diagnosis, the children diagnosed at 18 months and 24 months were relatively similar in terms of language delay and other evidence of developmental delays. It's interesting that the children diagnosed at age 3 had relatively typical language and nonverbal skills. And again, this is at age 2. So they presented as, kind of doing relatively well and on a statistical basis, very much distinct from the earlier diagnosed kids. I just want to acknowledge the work of Ilan and team. Kind of looking in the community, it's also true that that language scores, language skills do differentiate children on the basis of the timing of the diagnosis. I think often when we're thinking about what occurs in the community, we tend to make the assumption that people just need to be looking for autism more carefully, or perhaps they don't have as much experience working with young children who don't have language delays. And I can't say that we are the be-all and end-all of early diagnosis, but these are 18 and 24-month-olds who are having ADOSs and sort of seeing an experienced team, and they were still honestly flying under our radar. It's interesting. So the lack of language delays is consistent with the difference on the Vineland and an adaptive scale, although it's interesting that functionally we are seeing in that even at age 2, the children who go on to a diagnosis of age 3 are on a group basis, are a little bit below average. The other interesting thing is on the ADOS, it wasn't like they were asymptomatic at age 2. On an average basis, they were sort of right at the threshold that we, in terms of the comparison score that we would typically associate with autism. So you could ask the question, well, why didn't we diagnose them with autism? I think it's because they had an ambiguous presentation. We were concerned, but we really didn't feel that they met the overall threshold in terms of DSM. And I have to say, this group of families who had a lot of experience sort of going through the diagnostic process also did generally not feel that these children had autism. In fact, we found that the balance is after having an older child, and often a child who had a more kind of prototypic or obvious presentation in terms of the severity of symptoms and the degree of developmental delay, the contrast with the younger child sort of made it a bit more difficult to broach the conversation about a possible diagnosis, given that ambiguity and subtlety. So there are some really important implications. So as I alluded to, whenever we're looking at a predictive marker, whether behavioral or a biomarker, especially if we're using machine learning, we're kind of calibrating or entraining it to a particular endpoint. So it's important to note that even that training to a 2-year diagnosis is actually very different than in training to a 3-year diagnosis. And even as a prediction of 3-year diagnosis, a 2-year diagnosis, at least in our hands, only was about 50% sensitive for a 3-year diagnosis. So this notion of sort of like one stop is going to be, in terms of assessment, is going to be sufficient at an early stage to identify all children with autism, I think is going to be improbable. I think this whole notion of instability also needs some revisiting. I don't think that children are unstable. Really, they're following a pretty steady pattern of development. I think it's actually our own clinical judgment that's unstable. And to some extent, that comes from having less experience with children who have a more subtle presentation in early age. And it also comes, and I'll show this in a moment, from the notion that when we make a categorical diagnosis, children exist on a continuum in terms of symptom severity. The children who are far away from our diagnostic threshold, even if they move a little bit, it's unlikely that they're going to shift classification. However, if they're kind of close to the dividing line, it doesn't take a whole lot of movement for them to flip from sort of meeting our criteria to not meeting our criteria, or vice versa. From a clinical point of view, I do think we have to be really cautious about ruling out a diagnosis when a child is referred or when we're seeing them in an early stage. It seems obvious, but in a strained system, often families, whether explicitly or implicitly, they have one shot at the diagnosis, and we have to be very careful with that. I'm just going to present what kind of new data that we're just writing up, and that is kind of looking at sort of change in diagnostic classification as you look a bit further on. Actually, in this case, only at age 5. So clinically ascertained cohorts. So Kathy Lord has this beautiful study where she's followed a group of children referred in as preschoolers and now into adulthood. Changes in diagnostic classification largely occurred between ages 2 and 3 and not after age 3. In our cohort, the children who were diagnosed at age 3, most of them were diagnosed at age 5, but not quite as many as you might think, sort of based on sort of the expectation of stability at age 5. What we found particularly intriguing is that of the 10 children that did not meet criteria at age 5, despite meeting at age 3, 9 of them didn't meet criteria at age 2. So again, this emphasizes this notion of creating sort of a bit of an artificial dividing line kind of among children on a continuum of symptoms. I have a colleague who works with the IBIS group that used machine learning to kind of identify sort of kind of a statistical cut point and looked at how that mapped onto clinical judgment. And again, it's not surprising that children on the continuum close to the cut point, because it only takes a bit of movement on that continuum to shift classification. I mean, it is exactly the group that are kind of right at the margins who may shift. But I think it is a good reminder that children who have an ambiguous presentation early on are the ones we really need to pay attention to because of that complexity. And again, this was based on an independent assessment. Clinically, I'm not so sure that a child who met at age 3 and is a little bit below my clinical threshold at age 5, I don't know that we should be withdrawing diagnoses. I mean, I think, again, it's the same child. We just haven't quite calibrated to this subtle group. And at age 2 and 3, we're much more used to seeing children with severe symptoms, significant language and intellectual delay. And we have a lot to learn about these children with more subtle presentations. All right. With the limited time I have left, I'm going to shift gears yet again and just acknowledge, yeah, we've done a lot of this early detection research. It's a busy slide, but it really begs the question of, how much progress have we made in terms of age of diagnosis? Unfortunately, this table isn't particularly organized by year, but rather by country. But largely, the average age of diagnosis remains between 3.5 and 4. And that's mostly based on studies that have an upper ceiling of the age of detection. So for instance, in the US, Developmental Disabilities and Autism Monitoring Network, those children are included based on sort of if they have the diagnosis at age 8. And they've kind of plateaued out at an average age of diagnosis of around 4, sort of despite sort of this growing knowledge about early signs. So why is that? I mean, I think that when a lot of us got into this business of working with younger siblings, we thought, well, if only we could sort of figure out what the earliest signs were and conveyed that to our colleagues, that we would be diagnosing most of the kids at 18 months or at latest 2. But of course, that assumes that that general knowledge about early signs of autism are the main are the main bottleneck or barrier to diagnosis. But again, I think I'm interested to hear sort of what things are like in Israel, but certainly in North America, the bottleneck is largely the mismatch between the sort of the human resource capacity around people that do autism assessment versus the number of children that are identified and referred. And honestly, a lot of our community colleagues are kind of giving up on us. So if they're, they may have lifted their threshold a little bit, because if they're not sure, they do, kind of based on qualitative research, they may hesitate to make a referral if they know that that family is going to just kind of wait a couple years sort of with the concern. I think that it's impossible not to conclude that we need to do more than identify earlier and earlier features. And we actually need to think at sort of more of a health systems level. I think we've talked a lot about measurement today, and that's certainly an innovation in diagnosis. I think we can also be thinking about sort of what happens at a system level, and in particular, how we sort of build capacity in terms of the human resource side. So this is a discussion that's been going on for some time. This was a commentary by Zach Warren and I that sort of came out of a very thoughtful commentary that sort of raised concerns about kind of with shifting approaches to diagnosis. What if it sort of undermined the integrity of diagnosis? And both in terms of relying more heavily on technology and also sort of exporting and sharing the responsibility of diagnosis with community physicians. I was interested to hear last night, just over dinner, sort of the expectations, kind of the criteria to be eligible for services in Israel. And if I understand correctly, there needs to be both a physician and psychologist involved. And then I think typically the physician would be someone who has a kind of a specialized role in autism assessment. One might argue that if we're going to increase capacity, that we need to get a bit more comfortable with sort of expanding sort of our approaches. And I was thinking about it ahead of this talk, and it was like, well, we need to kind of build relationships and kind of increase the reciprocity between our specialty teams and the community, and we need to kind of become comfortable with kind of changing our diagnostic routines. So, we work in the autism field, we can work through these issues, right? I think some of this came to a head during the pandemic because we've tended to think about autism diagnosis and sort of gold standard and best practice largely in terms of measurement. So children should get the ADOS, sort of who are the professionals that should be around the table in terms of making a diagnosis. But of course, during the pandemic, we weren't able to do the ADOS. And I think it came to the surface some of the disparities that were kind of present in the system, but were more obvious to us sort of when our capacity dropped even further. And I think the experience of adapting to a changing environment sort of, I think has been really difficult and stressful, not the least of which for families, but I think it does give us some inspiration in terms of kind of adapting sort of how we approach things. So I have to say, in Canada, and sort of based on good data, we've started to rethink about what constitutes the gold standard in autism assessment. And it's at the view not only of the individual child, but sort of what's happening at the health system. And the risk of a one-size-fits-all approach that, if there's a certain level of assessment that can achieve an accurate diagnosis, good family experience, supports the family in navigating for service, if we end up investing time and resources, 2- and 3-fold in terms of what really was necessary to achieve those goals, frankly, that's another 1 or 2 children that are still on the wait list because we've kind of tripled our time and the number of people involved. So, sort of thinking about sort of how to tailor our approaches to the level of complexity of clinical presentation, and sort of think beyond measurement and accuracy of classification to sort of what we're actually trying to achieve in diagnostic assessment. And that is an understanding of the family, preparing them to navigate the system, accessing services, and doing it in a way that is child and family centered and culturally safe so that they're leaving with a sense of hope and feeling respected and empowered. And I'll present data. I mean, I personally, and certainly there's growing consensus that this can be achieved using multiple strategies. And the whole notion of multiple pathways to diagnosis is starting to get some traction. I think partly because, again, the training of specialized team has just not kept up with sort of the need based on clinical referrals. Here's the systematic review that I completed with a couple colleagues. This is sort of relatively kind of a relatively small literature, but there are several independent studies that have looked at the agreement between community physicians and a specialty team sort of after the community physicians have gone through a training process and some ongoing mentorship. And the agreement is good, and because the agreement is good, that you can achieve kind of greater number of assessments and reduction in wait times with very high parent satisfaction. I think one of the best studies in this area just came out a couple months ago that was led by a colleague of mine, Melanie Penner, a developmental pediatrician in Toronto. She works closely with Jessica Bryan, who's been involved in the SIB work as well as the social ABCs, and also Evdokia Anagnostou, who's kind of brilliant autism researcher who I think was an invited presenter here a few years ago. And she looked at sort of the agreement between community pediatric diagnosis and the diagnosis by a specialty team. And for this group of community pediatricians, they were largely seeing children that they were referred, not going through a standardized training process, but there was a community of practice. I mean, there was some interaction between those pediatricians, an opportunity to reach out to the specialty team, but they tried to see sort of without actually sort of directly influencing the skill set of the community pediatricians and allowing them to self-select how they were doing. So for the most part, they were actually doing pretty well. It's not surprising that there were higher levels of agreement between the community diagnosis and the specialty diagnosis when the community pediatricians felt relatively confident. But the overall level of agreement was roughly 76%. And the disagreements were more among the cases where the community pediatrician was less confident and frankly more inclined then to reach out to the specialty teams. So this is not a rigid process, but rather a bidirectional process where a specialty team could sort of identify at the intake stage the children that have a more straightforward presentation for assessment in the community. And likewise, the community pediatricians can say, I'm kind of out of my, this is a bit I'm a bit out of my depth here and I need some support from the specialty team. Not surprisingly, the accuracy overall was not as high among the community pediatricians when the kids had a more subtle presentation, those kids that tend to be diagnosed later. Again, out of the dinner conversation last night, I really want to emphasize that these community pediatricians were not over-diagnosing. On a statistical basis, if anything, they were under-diagnosing because there were actually more cases that they didn't diagnose that the multidisciplinary team did than vice versa. I think this is very different, though, than a pediatrician working in isolation. These were pediatricians that were part of a community of practice. I mean, they had a connection to the specialty team. They knew that they could reach out if they had questions. And although we can appreciate that there are pressures on our community colleagues to make a diagnosis, advocate for their families to get service, I also don't think that any one professional discipline has the monopoly on sort of clinical integrity, right? Like we have those same pressures as well. So I would be cautious about assuming that community physicians and as well, of course, community psychologists are going to be somehow more susceptible to those pressures than necessarily we would be. One of the aspects of this community of practice is this telehealth training platform that, again, has really gotten a lot of traction. This is a very simple model. There's a group of people that kind of get together on Zoom. There's a specialty team that facilitates, and then a group of community professionals or community practices. And the way it's organized is the community professionals present a case. And what's a little bit different than traditional telehealth is that their community colleagues do most of the heavy lifting. So rather than the specialty team giving advice, asking questions, it's really the community colleagues always go first. And then there's this sort of growing expertise and sort of kind of collective sense of community in terms of supporting one another around sort of making kind of learning about subtle differential diagnosis and also more broadly around autism care. We've implemented this kind of training program at our own center. It's a combination of this echo-based case discussion with some kind of formalized didactic training. And then I think the middle stage, I think, has been really helpful for us. And that's kind of mentored office assessments. So it's a nice bridge between the classroom, teaching even with hands-on experience, and actually becoming more confident in doing their own assessments. So I have a colleague who would then go to the pediatrician's office, see a few kids together with the pediatrician, do a little bit of real-time coaching, and then when they've had that experience, then they present their cases online. And they're really good, actually. I mean, we're fortunate in Canada where pediatricians are used to taking on a consulting role rather than a primary care role. It's not necessarily all the pediatricians, but there's a significant subset that have a real strong interest in developmental care and mental health. I don't want to oversimplify, because there's no question that among individuals on the autism spectrum, there are some with a level of diagnostic and medical complexity that they do warrant a multidisciplinary team. They warrant sort of more intensive medical follow-up for these co-occurring conditions. But it is sort of potentially a minority. And I do think that this notion of sharing the work of diagnosis is part of this broader shift from thinking about autism as a rare condition that always requires sort of like a specialty center, a specialized team, to really thinking about autistic children and adults as kind of members of the community who need good health care. And there are some benefits about integrating diagnostic capacity into the communities in which they live. I mean, certainly those professionals have a better understanding of local supports and services and how to navigate. And the potential to link diagnosis to ongoing health care also has some benefits. I'll just sort of finish acknowledging that this is not always easy. I've had an administrative role in Edmonton the last few years, so I've worked really closely with these community pediatricians. And honestly, after the excitement of seeing many of them step up and doing a fair number of assessments, they've actually had to pull back sort of under the pressures of the additional kind of health challenges that have been experienced in the pediatric community. A lot of the research that needs to be done around creating this community stream is less about sort of the training models and achieving accuracy, because we're pretty confident in doing that with the right group. It's much more actually about scalability and sustainability, and how do we help our community colleagues sort of find a balance where they can actually continue to maintain their responsibility around general health care, but also kind of commit to aspects of autism care. I think the other big question is most of these training programs have focused on preschoolers, and largely the highly selected preschoolers, so they have a more straightforward presentation. like all of us, we kind of start with a certain skill set and then we learn on the job. So theoretically, we would like to think that these community professionals could start to see older kids and kids with more subtle presentations. I think we also know that there are some potential risks and downsides in that in terms of sort of pushing those boundaries and the risk of misclassification. And this remains an empirical question about whether we can achieve this. And I know I'm running low on time. I'll just say in terms of that scalability and sustainability, some of it is just sort of making it a little easier for our community colleagues. And the things that make our jobs easier as diagnosticians apply for that group. So having good report templates, having the information pulled together about supports and services, making sure that they're confident not only in assessment, but how to talk to families and also talk to autistic people are also really important. I think that we have also found that the community pediatricians have a lot more credibility with their colleagues than we do. So having a local champion who can become directly involved in the training process and really champion the approach in the community can be very helpful. I won't go into detail about this. There's a lot of dialogue in Canada about how to build a better system of care for autistic people, including around diagnosis. And there may be sort of specific strategies that may be helpful, including rather than just sort of going out into the community, making specific, more intensive training available to community professionals that want to take on a diagnostic role. And certainly from the UK, thinking about influencing the system of care by setting specific benchmarks, which of course, are hard to sustain, but at least they set a specific goal. Briefly, and isn't this typical? So, it's supposed to be about timely diagnosis, and I'm mostly talking about preschoolers. I just say that and I was commenting on this to some friends earlier. I just feel like we have a collective responsibility, even if our professional experience is with younger kids, to really think about sort of building capacity across the lifespan. Partly because that infrastructure and capacity largely doesn't exist, especially for adults. And the reality is, if we're all working with preschoolers, these are kids that are not being detected by the system of care during those years. So I think that we have to really be thinking about the autistic community as a whole, and be willing to sort of move outside of our own comfort zones, at the very least to be working with colleagues that have experience around the age groups, but maybe not sort of a specific background in autism. So just to finish up, I do think, even as someone who sort of worked on infant SIB research for a number of years, that timely diagnosis is a helpful guiding concept, that it goes way beyond early detection and screening, in part because of the diversity in autism, and that our current early detection and screening processes are not really serving a certain segment of the autistic community who may be identified at a later stage, partly because the features may not genuinely consolidate into a diagnosable condition until a somewhat later stage, and because autistic people have so much to contribute, and that opportunity to benefit from supports and services, and that sense of community is actually really important as people get older as well. Clearly, it is a delicate balance of maintaining the integrity of the diagnostic process, but responding to this insufficient diagnostic capacity. Again, I'll return to the notion that we've all kind of largely got through the pandemic now. In the clinical world, we've all had to somewhat change the way that we practice, and I think that we all recognize that we have the ability to do that. And it is an exciting time, but again, there are still more challenges than ever, not the least of which the kids we didn't get to see and the adults that we didn't get to see over the last few years that are still waiting for us. So I just want to thank you all. I want to acknowledge my many wonderful colleagues, both in the labs and many kind of friends, colleagues, and mentors from over the years that have guided the ideas in this presentation. So sorry to take so much time. I hope there's time for a couple of questions. Thanks very much.
Lonnie, something that I've always been curious about is this big difference in the amount of autism that you see in the baby SIP study versus population studies, like in Scandinavia, because there's where it's almost 2 or 3 times higher in the baby surgery. Can you elaborate on that a bit and say like higher sensitivity and what do you think?
Yeah, it's such a great question. Like, why is there a difference in the recurrence estimates that are coming from the infant SIB research versus population-based research? Where it's interesting that population-based research, the recurrence hasn't changed all that much from research done 20 or 30 years ago, despite the increase in population prevalence. So I think that probably the true answer is somewhere in between. I think that there are advantages in both strategies. I think the population-based is a reflection of sort of what actually is currently happening in the clinical world. I think in the infant SIB research, there's much more careful surveillance and an opportunity to diagnose at an early stage children with a more subtle presentation. But I do think this observation of remitting diagnosis does raise the question of whether we're actually identifying and diagnosing children through infant SIB research that might have flown under the radar at 2 or 3, and then if they came to attention at 5 or 6, maybe not identified as having autism. Of course, the big question is what then happens with those 5-year-olds? Are those the individuals who by age 18 are being diagnosed with autism or should be diagnosed with autism? And I think that the limitations both of prevalence research and also of recurrence research is often there's a bit of a cap on ascertainment age. And again, I think we're still learning about sort of the continuum of presentation and sort of what the cumulative prevalence might be if we actually included the adult years.
Thank you for the great talk. If I may, sometimes we hesitate what to do with the very young infants that we don't expect them to, peer relationships, but the diagnosis is so obvious. And here in Israel, and I guess also in Canada, in order to be eligible to go into the early intervention, we must give a diagnosis, DSM, so what do you do with these cases?
Yeah, it's a great question about the challenge of applying DSM criteria to these very young children, especially when there's sort of evident presentation. I have to say, I feel like DSM-5 gives us a bit more flexibility than DSM-4 because it's about social relationships rather than peer relationships. So I do think, and I didn't emphasize the data, but we have a number of children that we've kind of given a clinical diagnosis at age 18 months, and 90% of those kids continue to hold on to the diagnosis at age 3. So I do feel the diagnosis is warranted when the DSM criteria are met. I also have the experience sort of both in a research context and also in the clinic. You see 18-month-olds that like some thoughtful community professional has referred, and you're still not quite sure. And I think it's in that scenario that our system needs to be much more flexible to provide supports and services, because the truth is the supports and services aren't treating autism, they're treating particular developmental targets that I think we can be much more confident about. Early nonverbal communication, social engagement, and so on. So it's a bit of an uphill battle because so many services are, the gateway is a categorical diagnosis. But I do think that if we want to push the boundaries around earlier detection, we need to recognize that no matter how good we get, there's probably going to continue to be a window where we're worried and we're confident about the diagnosis. And it's a shame not to act during that period.
What about using the
0.5? I agree. I mean, I'm trying to remember, what's the exact term that's used? Not presumptive, but there is a diagnostic category of I think it's autism, right? So I think I have child psychiatry colleagues that have really advocated for that system clinically, and I think it has a lot of merit. I think my only hesitation is, I think that even that may be setting the bar too high to sort of say, I really think this child has autism versus there's clear social communication concerns here. Let's get started with intervention. Yeah.
Perspective that looks at traits, abilities, and difficulties beyond the categorical classification. That potentially says that we could ask not only for very young kids, but also for older ones to get support through the social health system even if they don't meet criteria.
Well, and that may be a wonderful segue to our panel, because I'm excited that my colleague Jen Zwicker is here from Calgary, who's done a lot of really good work in this area. I feel like they're somewhat distinct but interrelated issues, like sort of a less categorical approach more generally, and then a more flexible approach early in life. Because I think no matter our progress, unless we sort of move to a more biologically defined classification framework, I do honestly think that no matter how good our clinical observations are, I'm just not sure we'll ever fully close that gap between early detection and diagnosis. And I'm not sure that we should. Like, I feel like those children are somewhat fluid. And I think that in the same way that the children with autism were distributed among those trajectories, I mean, clearly there were some children who didn't end up having autism that had features identifiable in the AOC that I think clinically were actionable. So this notion of sort of actionable findings as opposed to categorical diagnosis, especially early in life. But at the same time, I do feel like there's a rationale to move to a more flexible, needs-based system. So yeah, conversation either maybe for later today or another day. Thank you. Great, thank you, Lonnie. I will. I'm going to grab my notebook.
Okay, sure.
Okay.
So